So today we'll be discussing a very interesting topic and a very commonly occurred topic, that is pleural fluid analysis. Now the thing is, pleural fluid analysis is usually very much commonly required, and most of the time, the basis for that is whether to see whether it is an infective or non-infective, because very commonly what we get, pleural effusion we can get unilateral, bilateral, and in presence of congestive heart failure or heart failure or CKD or fluid overload, it becomes very difficult to understand what is the reason for this effusion. The effusion can be gross, it can be moderate. So, what exactly is causing this infection? Whether there is an infection or there is the component of this heart failure or CKD or fluid overload or hypoalbuminuria remains very important. So, in pleural fluid analysis, the color of the pleural fluid should be more of a colorless or straw colored. So, if we see that this color of the pleural fluid is almost very dark reddish or hemorrhagic, then it can mean, if it is hemorrhagic, it may mean two things. The chances of malignancy can be very high in that particular patient, especially if the patient is elderly, cachexic. So, if it is hemorrhagic, then we should always think of malignancy. And second thing, patient may have trauma. So if there is trauma, then the patient is definitely bound to have hemorrhagic pleural fluid if it is trauma related. So that will be then, in that case there will be hemothorax in that particular case. Otherwise, the chances of gross hemorrhagic effusion will be lesser. The second thing is then the turbidity. It can be slightly turbid, but if it is turbid or if it is very thick, if it is thick, yellowish, or cream colored or white mucoid, then it definitely means that it is infective. The chances of having it infective becomes very much more if it is turbid, if it is yellowish, it is cream color, white color, or mucoid. And most of the time it is bacterial, though in rare cases it can be fungal as well. Now, presence of cobwebs formation whenever this pleural fluid is kept in the dish, petri dish, there becomes a formation of cobweb. Now, this cobweb formation is very suggestive of tuberculosis. So, if there is formation of this cobweb, then the chances of having it a tubercular pleural effusion becomes very high. In this particular patient, cobweb formation was there, and this patient had actually tubercular pleural effusion only. Now the next thing is coagulum. Now coagulum is basically, we know coagulum comes from kind of clot or a coagulation system. So in coagulation system, we'll be having fibrin deposition, RBCs, and there will be so many inflammatory cells. So coagulum is not very specific for a particular thing. It can be seen with malignancy, it can be seen with tuberculosis, it can be seen with infective focus, it can be seen with inflammation, as well as it can be seen with pulmonary embolism. So I'm kind of going to skip this thing. And the next most important thing is protein. We know that pleural fluid should have proteins. Normally, it should be less than 2 gram per deciliter. So, one or two, or if the proteins are less than 2 gram per deciliter, it can definitely suggest transudative pleural effusion. It can definitely suggest transudative pleural effusion. If the uh, proteins are more than 2 gram per deciliter, then the chances of it having exudative is very high. And we know, whenever we see exudate, it means most of the time it is infective, or it can be inflammatory, significantly inflammatory. So when we say it as exudative, the proteins will be more than 2 gram per deciliter, and most of the time when we say exudative, it will be bacterial pleural effusion. It can be TB or it can be anything. It can be Proteus, Staphylococcus, Streptococcus, Pneumococcus, anything. It can be fungal pleural effusion also. And in rarer cases or in less common cases, it can be related to malignancy also, or it can be related to inflammation also. So the inflammation can be because of the systemic inflammation, that can be because of the sepsis, or that can be because of the any of the cause. So if there is systemic inflammatory response syndrome, there can still be exudative pleural effusion. So most of the time, if it is exudative, whenever it is more than 2 gram, we are almost always sure that the chances of it having heart failure, or simply due to ascites, or simply due to hypoalbuminemia, or simply because of the CKD, becomes very very less. So the chances is very high that this is infective only, and most of the time it is bacterial only. Then comes the glucose level. Like glucose level, it should be around 2/3 to up to the level of blood sugar level. So we have to always check the blood sugar level of that patient at the time of doing the pleural fluid tap. So it should be around 2/3 of the patient's blood sugar level. Then that is considered normal. The next most important thing in this pleural fluid is cells, because this is very very important. Because normally in pleural fluid we should not get any cells. You can get 1 or 2 or 3 or 4 or 5 cells, but if the cells are more, it means there is problem. There is problem. Now in this particular thing, we are seeing 1700 nucleated cells, which is pretty high. Ideally there should not be any cell, or if the cells are present, there can be 1 or 2 or 3 or few cells can be there, and most of them should be lymphocytes. But in this case, the total nucleated cells are 1700. The protein is high, means there is huge number of recruitment of the nucleated cells. Among this, if it is mainly neutrophil dominant, then we know that this is very highly likely to be a bacterial infection. And this bacterial infection can be pneumococcus, streptococcus, E. coli, proteus. Any gram positive or gram negative infection can be definitely there. But very commonly, lymphocyte predominance is seen in viral, or very commonly, most of the time, tuberculosis is the most common culprit. So the cells are very high. Usually in viral pleural effusion, you should not get this much of nucleated cells. The nucleated cells are high, the protein count is very high, presence of cobweb is present, and the 85% of these cells is all lymphocytes, which highly suggests tubercular pleural effusion. And apart from this, RBCs are present, but these are not that much in quantity, as because of this effusion, because of this exudate, there is definitely damage to the small and small capillaries many of the many of the times, because of the prick also, because of the drawing needle into the pleural space also. It ruptures the smaller blood vessels, and the RBCs can be seen. The other things which we need to see is the most important test which we should always do in pleural fluid is ADA, because elevated levels of ADA again very highly suggest tuberculosis, whereas a normal ADA levels doesn't exclude TB, but then goes against the possibility of TB. So presence of positive TB or a raised ADA levels definitely suggests tuberculosis. The other things which we always must do is gram stain, AFB stain, or ZN stain for tuberculosis, then fungal stain, then culture and sensitivity, and gene expert for TB. These tests should be always and always considered in patient who has a pleural effusion. In gram stain, it can definitely try to see whether there is some gram positive bacteria or gram negative bacteria. So whether they are in cocci form or in chain form, so we can have an idea. If they are in chain, then the possibility of streptococcus or pneumococcus is very high. If they are in cocci, then the chances of having staphylococcus can be definitely high. So depending on what exactly, whether it is gram positive or gram negative bacteria, we can give the antibiotic as per the gram positive or gram negative bacteria presence. Second thing is this AFB, that is acid fast bacilli stain or Zn stain. It is for tuberculosis, where we can very commonly see, if it is positive, then most of the time it is Mycobacterium tuberculosis. And then we, once AFB is confirmed on the pleural effusion by AFB or Zn stain, then we can definitely start the patient on anti-tubercular drugs. Fungal stain can be done in selective cases, where especially the patient is elderly or cachexic or is suffering from so many days, or the patient who is hospitalized for in the hospital for a long period. And it can be done, KOH mount can be done. And if it is needed, then fungal culture and sensitivity can also be considered if the patient has received multiple higher antibiotics, or the patient had multiple hospital admissions earlier. Culture and sensitivity can be definitely considered, because many of the times patient may have undergone multiple hospitalization. So what exact antibiotic has to be used can be definitely guided by this culture and sensitivity report. And the most important is gene expert for tuberculosis, because gene expert can definitely, sorry, ADA and AFB stain can definitely come negative, or they can be very inconclusive. But if gene expert is positive, then with presence of with presence of cobweb and with appropriate history, the patient can definitely be started on anti-tubercular drugs. So to start a patient on anti-tubercular drug, if the patient has pleural fluid, then the most thing is AFB stain or Zn stain, which should actually tell us whether the patient has tuberculosis or not. And the second thing is gene expert. If gene expert is positive, or AFB stain or Zn stain is positive, we can definitely start the patient on anti-tubercular drug, especially if the other things are also supportive, like proteins are high and total nucleated cells, especially lymphocyte predominance is there, or ADA is also high, or cobweb is also high. But out of these two, if any one is positive, that is more than sufficient to start a patient on anti-tubercular drugs. So for now, this is all, and thanks you for kind listening.